Our last talk in this glorious feast of science this afternoon and of all today is by Peter Piot. Peter is the 2015 winner of the Gairdner Global Health Award. And as I quoted from the Whiteman, I'm going to quote from the book on the Gairdner Global Health Award. The Canada Gairdner Global Health Award is given annually to a single individual who has made seminal discoveries or major scientific advances in any one of the four areas of basic science, clinical science, population health, or environmental health, and has made or has the potential to make a significant impact or health outcomes in the developing world. I said that Janet was an exemplar of the Whiteman Award, and I think Peter is ditto, an exemplar of what we look for in the Global Health Award. Peter has made major contributions, first in his co-discovery of Ebola virus back in the 70s, to the outstanding leadership he provided to the world as the first head of UN AIDS. And I think it's a measure of Peter's character and personality, as well as his deep understanding and appreciation of science. I think Peter's work at the UN AIDS exemplifies what leadership is all about. Now, if you read a book on leadership, you'll hear the 10 things you need to know as a leader. And of course, after the first or second, you forget what the first one was, and on you go. At CFAR, we have a Australian laureate fellow. His name is Alex Haslam from Brisbane, Australia, who has written a book called The Psychology of Leadership. And what Alex says, which I think resonates certainly with me, is to be a leader, you need followers. Seems obvious. And followers actually give to you the right to lead, because you exemplify for them the values, the goals, the missions, the personality, the dreams that they have and that the organization has. I suspect we went through that in the last election here in Canada, actually. And I think Peter has truly exemplifies leadership according to Alex Haslam's definition of leadership. And he's done it in a field, HIV, which is a very complex group of individuals and organizations. That field, as you know, or many of you will know, is made up of scientists. It's made up of patients, their families, larger communities. And those patients and families and communities range from the gay community in New York to dirty needle users in Eastern Europe, Russia, and the east end of Vancouver, to heterosexual HIV-positive couples in sub-Saharan Africa. Very, very different groups of individuals who are affected by that virus. It's also made up of global organizations, the WHO, probably dozens or hundreds of NGOs, not-for-profit, non-government organizations, each of which have their own agendas. It's made up of governments in all the countries I just mentioned. It's made up of activist groups who have their own agendas as well. And no one has managed to navigate the complexity of that landscape better than Peter Piot. And he's done that not just to navigate it, but he's brought all those diverse groups of individuals and organizations together under one roof with one common goal when he was head of UN AIDS. It really is a remarkable, truly remarkable achievement, and I think it speaks to Peter's personality in very many ways. He's really managed to, I think, articulate the dreams and hopes of everybody who works on or is affected by that virus. I first knew of Peter, of course, when I interested in health research. I've learned how do you not know about HIV, and then when I started working on in New York on the global HIV vaccine enterprise, and Peter became chair of my board, and that board, in a true sense, also just exemplified in a microcosm what I just talked about in terms of the diversity of goals and objectives and dreams. So I think this award to Peter is a much-deserved recognition of Peter's leadership, his multifaceted recognition of the importance of moving forward, speaking with a clear voice, sometimes not a popular voice, indeed, I would say frequently not a popular voice, but sticking with it because he knew where he wanted to go by the end of this journey. Peter, over to you.
Thank you so much, Alan, and good afternoon, everybody. I'm deeply honored by the Gairdner Award and also by the recognition of what was not the most typical scientific and other career. And I've been very privileged to be associated with what retrospectively are the two defining epidemics, infectious disease epidemics of our time, Ebola and AIDS. And so in contrast to the previous lectures, I'll go from the, not the molecule and the cell to the macro, but anything in between, and that takes to basically change the world. And when I was last year in medical school, it was in '74 in Belgium, in my native country, the advice of my professors was unanimously that there is no future in infectious diseases. And I was interested in microbes, in epidemics, and so on already, even already when I was in high school. And don't we have antibiotics? Don't we have vaccines? Don't we have sanitation and so on, and hygiene? And yet I went for it. I went for a PhD in microbiology. And while I was also in training in infectious diseases, blue thermos, Chinese thermos, arrived at the reception of the clinical microbiology lab that I was working in, dropped by a pilot coming from Kinshasa, the capital of what was then called Zaire, and now the Democratic Republic of Congo. And in that thermos were two glass vials, because there was not much plastic in these days, and some ice cubes, and one vial was broken, and the sample was swimming in there, and it contained blood from a nun, a Catholic missionary, who had died with a mysterious disease, and the diagnosis was yellow fever, ? So we did our work. In these days, no PCR, no probes that you could do. Virology was a very artisanal type of science, maybe, or démarche, I would say. You inject mice, you inject guinea pigs, and you put it on cell lines. And out of this, we isolated what is now known as Ebola virus. And this is from the paper in the Lancet. We were instructed, after having isolated the virus and also after having seen under the electron microscope that the morphology was very atypical and only resembled one other known virus at that time, and that was Marburg virus, which had caused a small epidemic in Germany, in Marburg, among laboratory workers who were preparing polio vaccines on the polio virus that was grown on African green monkey kidney cells that were infected with Marburg virus. Again, the only way in these days to identify new viruses was through cross-neutralization, immunofluorescent, and all these techniques, and that was done at the Centers for Disease Control in Atlanta, in the US, because we were no longer allowed to work with this virus when it was clear that this was a part of an epidemic of hemorrhagic fever, and we only had a category 3 type of virus. So that was very exciting. I was 27, and I immediately volunteered to go to Central Africa to figure out what was going on there in the field, how this virus was transmitted, how it was spreading, what the clinical expression was, and so on. I had never been to Africa. I had zero experience in investigating epidemics, but most people who were more senior than I was were not very keen to go there, so that was my chance. And here on the left side, you see how the kind of protective gear that we had. This was Pierre Sirot from Institut Pasteur in Paris, and he and I were the two who were seeing patients. And our mission when we came there was threefold. One was to stop the epidemic. That's easier said than done. Put in place quarantine, isolating the patients. And we took the wise decision, which ethically was difficult, but may even have saved many lives. We decided to keep people in their houses, in their huts, rather than to bring them to a hospital where retrospectively now we know they would most probably have infected many others, including ourselves. Our own protection was not so great, just paper mask and surgical gloves, latex gloves, and some motorbike goggles. That's all we had basically, compared to what on the right side, what is being used now in West Africa. And the second objective was to take samples to confirm that this was indeed associated with this new virus. In science, you always need confirmation. And thirdly, to figure out as soon as possible the modes of transmission, because that knowledge is always the basis for epidemic control. Was this by air, fecal-oral, sex, mosquitoes, the usual ways that viruses are transmitted. And actually, this was also a time when we didn't have mobile phones, we didn't have access, internet didn't exist. And it was really by asking three very simple questions and talking to people that we figured it out. And the questions you ask, you try to define an outbreak like that in terms of time, place, and person. Where are we? How is this epidemic evolving? And we saw that there had been a peak and that epidemic was already coming down, and we asked what happened after that peak. And it turned out that coincided more or less with the closure of the hospital, because people had seen that something was wrong in that hospital. In terms of place, the closer you would live near that hospital called Yambuku, this mission hospital, the higher the likelihood that you would have Ebola. And thirdly, you break down people. You ask, who is it? Break them down by age and sex. Here on the in blue you see men or males, and and in red female cases of Ebola by age group. And you plot it out. The first thing we saw is that, and I was pretty reassuring, that actually relatively few children were actually affected, which goes basically against an arthropod-borne infection, mosquitoes and so on. But the most striking finding was that between 15 and 29 years of age, twice as many women as men were there was twice as many cases among women than among men. So the question was, first, does this reflect the demography, the local demography? Because in many places in poor countries, in rural areas, the men are not there. They're working in towns and so on, in the mines and what have you. But that wasn't the case there. It's a very isolated area in the tropical rainforest. And then the question is, what's the difference between men and women between 15 and 29? Since we were a bunch of men, it took us a few hours to figure out that women can get pregnant. And we double-checked, and indeed, the excess of women was entirely due to pregnant women or to women who had just delivered. And then the next question was, what happened? Is there a biological, immunological type of explanation or something else? And what we did was we tried to match the information we had from the collected in villages and that with the hospital records, which was pretty primitive. And it turned out that all these women had visited the antenatal clinic of the hospital. And all that we figured out in 48 hours, basically. But then the next question was then, what on earth was going on in that hospital? Everything pointed to something going on in the hospital, some kind of nosocomial infection, as we would say now. And that took longer to figure out, because what happened is that every day in the morning, Mother Superior would distribute 5 needles and syringes, glass syringes, which were used over and over again for about every outpatient who came. And nearly all medication was given by injection. There's no medical reason for that. And they were just flushed in kind of water, in clean water in between. So that was it's one of the most efficient ways of transmitting a virus, be it Ebola or something else. So that was the first observation. Very sobering also to give that message to the sisters who were trying to do a lot of good, but it's not enough to want to do good. You also have to be competent. That was certainly the first lesson that I drew from that experience. And secondly, when we looked at the hospital staff, and as been observed over and over again in Ebola outbreaks, including now in West Africa, where over 500 healthcare workers died from Ebola. 11 out of 17 hospital staff had died from Ebola. This is from another outbreak in Kikwit in 95, and where the beginning of the outbreak was all concentrated in hospital workers, lab technicians, nurses, doctors. And then thirdly, people told us that about a week after a funeral, that many members of the family who had attended the funeral would fall ill with Ebola. And again, that's what we've been seeing in West Africa. So these were the basic mechanisms that we identified. In other words, it has to do with very close contact, exposure to bodily fluids, and with transmission through contaminated needles and syringes. And in other words, it's also something that is not so easy to transmit because it requires very close contact. So after that, I went back to my training, and we, infectious diseases, worked on my PhD and all that. But then a few years later, there was another virus that appeared in my life, and that's was HIV. It didn't have a name yet. We didn't even know that this syndrome was caused by a virus. I didn't prove. And I was, after having spent some time at the University of Washington in Seattle, I went back to Belgium, and there we started seeing Europeans and Africans coming from Central Africa with this new syndrome. Looked fairly similar, although the opportunistic infections were slightly different. For example, far more tuberculosis than we would see in the European or indigenous patients in Europe. But the big difference was that 1/3 of our patients were women. That was very different. And then the dogma was that these days, this is a gay disease. It even had the awful name, gay-related immune deficiency. And frankly, I never could imagine why a virus would care about the sexual orientation of its host. That's a human invention, and for a host, for a virus, sex between humans is just it's a way to perpetuate life and to jump from one cell, from one host to another. So I went back to Kinshasa, and together with our Congolese colleagues and some colleagues from NIH and CDC, we unraveled that there was indeed a heterosexual epidemic in Central Africa that was unraveling. It was still very limited by the standards of today, but it really shifted the paradigm as far as AIDS was concerned in the world. Now, that was the beginning of about 10 years of intensive research, going from the virology. We documented that viral isolates from Central Africa had a much greater genetic diversity than in the rest of the world, indicating that the virus had been circulating there for much longer time. We identified very aberrant isolates. Secondly, we found that tuberculosis is very closely associated with HIV infection and is actually has been following the AIDS epidemic as its shadow, giving rise also to major problems of multi-drug resistant tuberculosis and even quasi-untreatable tuberculosis. And also making current and standard treatment regimens no longer effective. That was a major public health implication, and did then some research to find out why that was. We also did work on trying to prevent the spread of HIV at a time when there were no drugs. There was no antiretroviral therapy and so on. And just through social mobilization, condom use, which was about the only technology, quote unquote, we had, and we worked, as you can see here in this paper, that we published with actually colleagues with Michel Allary from Laval here in Quebec, that you can actually have an impact. And that was also demonstrated in gay communities all over the Western world before there was any biomedical intervention. And also, Martine Peters in my lab, she isolated the first simian immune deficiency virus from a chimpanzee in Gabon, and then later on in Congo. An isolate, SIV, CPZ, has about 98% homology with HIV, with the human immune deficiency virus. We had a very hard time publishing that paper because every reviewer said that this was contamination, which of course is not impossible, but we could confirm it from some other wild-caught chimps, and later on also at the University of Alabama they found it. And this is the ancestor of HIV. And the circle was round. Let's not forget when we talk about emerging infectious diseases, this is the acronym EID. It's not some terrorist group, but it's EID, and that they're all zoonoses. They all emerge from other animals than we human primates. And with Ebola, we know today it's most likely some kind of bat, although the virus has never been isolated from the bat. Pieces of RNA have been identified, that's this good circumstantial evidence, but not yet firm evidence. Chimps for HIV, influenza, the most common epidemic and pandemic is birds and pigs, and now we have MERS-CoV, coronavirus with camels. So that means that, and another lesson for me was that even if we're interested mostly in human illness and so human disease and epidemics, we need to work with our veterinary colleagues, and we need to look at all animals that we all are. So after having worked for about 10, 12 years on the various aspects of HIV infection, both in Antwerp and then also in Africa, particularly in Zaire and in Nairobi, but with our colleagues from the University of Manitoba, Frank Plummer and others, and really led the foundations of our current knowledge of the virology, epidemiology, clinical expression, and so on of HIV in Africa. I got into some kind of midlife crisis, and I said, every year they announced so many more million people infected, so many millions of more deaths. And I said, I don't only want to study the world, I want to change the world. I want to do something about it and stop it. By 1995, something that was the first publication on HIV was about 6 gay men in Los Angeles. And in the meantime, by 95, there were millions and millions of people infected with a major spread in southern and eastern Africa, Southeast Asia, and subsequently also in the countries of the former Soviet Union, particularly driven by injecting drug use. And here we go again, directly injecting HIV in the bloodstream of people. And so I changed completely career, the sense that I went to the policy level. I had no clue how to do that. I had no experience about it. and I had underestimated how political it was. When you say policy, actually policy, politics, it's near the same word, and in French it's even the same word, la politique. It was a big step, and I heard a lot. I learned it the hard way that scientific evidence is not enough. That was my naivete. I said, okay, we've got the data, we collect it, we have better data, and then we'll convince people, and that's it. And of course, that's not how it works in life. Now, we were lucky. UNAIDS was really came out in '96, and at a conference in Vancouver, the International AIDS Conference in July 1996, it was announced that if you give 3 antiretroviral drugs combination, you can treat HIV infection. That changed completely, of course, the life of individuals living with HIV, but also the perception of this epidemic, that it's no longer a hopeless case, no longer a death sentence. I would say recently something that comes closest is that the fact that we can now cure hepatitis C infection. No longer even it's a treatment that's even better than HIV infection and antiretroviral therapy. So it was really a miraculous, immediate translation of some really long-standing basic research into a treatment. And the big problem, though, was, as I said it at the opening session of that conference, I spoke there and I said, great news, many people's lives, will be saved. However, we should not rest until those in poor countries have access to this life-saving treatment, because that's where 90% of people living with HIV are living. And that's mostly in Africa, but also other low and middle-income countries. And that was easier said than done. This was in '96, and it would take close to 10 years before that dream, that aspiration became a reality. Because everybody said that, this was an absolutely impossible idea. That it was not possible because it's not possible, therefore it's not possible. And meetings were organized to prove that this was not possible, rather than, spend energy on trying to find out what can we do about it. It was a very interesting thing. Just as we had a hard time publishing our initial papers that HIV was also a heterosexual thing. And I should have kept some of the comments by referees. That one I remember said that it's a well-known fact that AIDS cannot be transmitted from women to men. That was in a very reputable journal, but anyway, in the end they accepted the papers. But so the common wisdom, that's why I'm very skeptical today when I hear that the common wisdom is X, Y, Z. Common wisdom in the 90s was that, reflected here in this quote from a senior economist at the World Bank in 1998, saying that the brutal fact was that those who could pay for Africa's AIDS therapy, the pharmaceutical industry by way of price cuts, and rich country taxpayers by way of foreign aid, are very unlikely to do so. And he was right. That was the predominant thinking. But all these people had neglected one thing, and that is that it's about people's lives, and that people can fight for their lives. And what's special about HIV is that there's a whole community, starting with the gay community, influencing the research agenda, but also in developing countries. This is in Durban, in South Africa, people literally fighting for their lives. And we had here a group of fairly young adults, many well-educated, not all, because certainly in Africa, for example, it's often a disease of poverty, particularly for women. And, they would not take no for an answer and would, increase the pressure on everybody. And that combined by what we were trying to do then in UNAIDS, when I become the head of UNAIDS, this a new institution that was created because of the failure of WHO to really take effective action. Sounds like a déjà vu after what happens now with the Ebola outbreak. That combined with, let's say, more diplomatic ways that was using resulted in the end in what I thought when I made my transition from pure scientist to someone also who has to think politically, was to put AIDS on the top political agenda. And I was thinking, after several years of working when we had no impact, no results, was thinking, at the end of the day, there are only two things that count, that matter, and that is, in big politics, it's security and it's the economy. And then the rest, okay, when there is money and time left, we can talk about health and so on. So we brought AIDS to the Security Council of the UN, the only body that really, the world takes seriously in the UN, I should say. They decide about war and peace and so on, even if it's not always respected. And so the first meeting of the new millennium of the UN Security Council on the 10th of January 2000 was chaired by then Vice President Al Gore of the US, because the US had the chair, you know, the chair rotates every month, and the chair, all the chair can do is to, you know, fix the agenda with my then boss, Kofi Annan, and they debated AIDS in Africa, the implications for security, for development. And there's been only one other debate on one other health issue at the Security Council, and that was last year on Ebola. And it made a real major difference. It opened doors. People who are normally only dealing with, you know, the big agendas of security and big economy and so on, we're starting to get interested in the whole, you know, in the whole issue and what to do about it, because we needed that leadership, and it resulted also in the African Union debating it, the UN General Assembly, and all that. All instances where I would never have dreamed ever, you know, even addressing. And after 5, 6 years, the results started coming up. And here you see the evolution of the price of antiretroviral drugs in US dollars per person per year in Uganda between 1998 to 2003, and that has continued. And in 1998, together with a number of drug companies, we were actually with Merck, Glaxo, can't remember what the others were, we had negotiated about a 40–50% reduction in price. Not bad, but far too high still for most people. And then through a number of, a combination of activism, of negotiations, but also the arrival of Indian pharmaceutical companies producing generics because of a change in the patent laws in India, and a change in the TRIPS agreements. The World Trade Organization has intellectual property agreements which said that in case of public health emergency, you can actually use generic versions of drugs that are still under patent, which would be illegal in otherwise. This is all kinds of things I got to know and to had to work on, and because I didn't want to, you know, to break all the patents, and because we need innovation. So how to square that circle and ensuring that we will continue innovation. So all this resulted in this major price reduction. But even with this kind of price, you still have someone who needs someone to pay for it. And that was the turning point. There was in 2001. You can see here the curve of funding, resources available for HIV in low middle income countries since 1986. And fairly flat. It went on up in 97 slowly. And then in 2001, we moved from what I had called for, from the M word to the B word, from millions to billions. And that was at a time when there were like 20–25 million people living with HIV in the world. The Global Fund to fight AIDS, but also tuberculosis and malaria, was created as a result from a summit of the G7 in Japan, in which also Canada obviously was very supportive. And then a year later, President Bush requested $50 million $15 billion from US Congress, and started what's called PEPFAR. And that changed completely the scene, and nowadays about 15 billion is available every year. The results are there. First of all, when you look at the lower curve, it gives you an evolution of the number of AIDS-related deaths in the world. It culminated in 2005 with about 2.6 million deaths every year. It still is the #1 cause of death in sub-Saharan Africa, but the number of deaths is declining now to 1.2 million in 2014, according to UNAIDS. And the number of new infections already start declining in 1997 as a result largely of prevention programs. So we are on a good trajectory. And so some say that the end is in sight. The end of AIDS is from The Economist. Some of it is, grounded in some very solid science. For example, there are studies that show that if you treat people with HIV, they become less infectious, which makes good sense. You suppress not only viral production, but also viral excretion, so they're less infectious for their sex partners. 96% reduction in serodiscordant couples. Also, other studies found that you can prevent HIV infection through sexual transmission through either a vaginal product, a microbicide, which we badly need because women still depend on an action by men, and so it's all under control of men when it comes to prevention of HIV infection in women. And that was a South African group showing that, or also pre-exposure prophylaxis in men who have sex with men. But I think we should be very careful and not to be too optimistic. It's not going to just take a few pills to end this epidemic. Lifelong treatment with antiretrovirals is quite a challenge, particularly when people are no longer ill and sick. I take some statins, and I forget now and then. That's okay. That's not a problem. If you forget your antiretroviral drugs, that's a real problem, and it generates resistance. It makes it inefficient. You select out resistant mutants and so on, because this is a virus that is fairly volatile. Secondly, we still have enormous levels of infection. In the Western world, there is a resurgence of epidemics of HIV infection in gay men in London, UK, where I live. Every single day, 5 gay men are infected with HIV, diagnosed. That despite free access to health care, the National Health Service, high rates of testing, a non-discriminatory environment, same-sex marriage, etc., just name it, because it's about sex. And when you look at Southern Africa, it's women, young women who are the most vulnerable and the most affected. And here you see from a nationwide survey in South Africa, and by the way, the data on HIV in Africa are quite good, the epidemiological data. And you see here in pink the prevalence, the percentage of women for a certain age group who are HIV positive. And you can see that for women between 20 and 24, already 17% are HIV positive. By the age of 35, it's more than 1/3. It's just staggering. And you can also see, compare that for the boys and the men, it starts a bit later. So these women are not infected by, the young girls, by the boys of their age. They're infected by older men. So this goes to the heart of what's driving the AIDS epidemic in some society. It has to do with gender, with gender-based violence, with poverty, with inequalities, and human rights violations. And it's not by just giving a few pills that we're going to treat us out of this epidemic. What we desperately need is an HIV vaccine. And we're not there yet, but even if the basic science is as good as it can get at the moment. And then finally, we have to see the mismatch between where the problem is. On the left side, you see the HIV prevalence, in other words, the millions of people with HIV infection. There are about 36 million in the world today, and concentrated a lot in sub-Saharan Africa. And then on the right side, the number of physicians working in sub-Saharan Africa as an indicator of what the health service can give. So we have to find to use innovative ways of dealing with that. Now, last year I became 65, and that's not unusual. That's, so for my 65th birthday, I went with my wife, with Heidi, to Ebola Ground Zero. It's probably the paper with the highest impact I've ever published. There was a report that we came out in the Financial Times Weekend magazine, and they put the term Ebola Ground Zero on there. I wanted to see how are things today where we first had the first outbreak, and also whether we could find back people who had survived. And we did. It was not easy to get there, but this is in Yambuko, in the hospital lab, and the man you see here is called Sukato. He survived Ebola in 1976. He was one of the few survivors. He was a nurse then, an aide nurse, and now he's the head of the lab. And this is the lab. This is all the equipment you see in the lab. We had some quite sophisticated laboratory experiments and results today. He has a microscope, which is pretty decent, you know, and the lights microscope, good. There's a centrifuge on the left upper side, and then all the reagents are on the one other picture. That's it. And it was really sobering. The hospital was in much worse shape, the whole environment, and yet in January 1977, WHO had convened a meeting with several donors and all that, and where there was huge commitments were made. Never again, strengthening health systems, you know, etc. You know, you can make all the list. And what had happened? Nothing. Absolutely nothing. An absolute scandal. So we need to make sure that that doesn't happen with the current epidemic. This was in February 2014. Little did we know that at the same time, a major humanitarian crisis was cooking in West Africa. And I must say that the 25 or so known outbreaks of Ebola in Central Africa, all in Central Africa, made me think that this would never become a public health problem. And when you look at the theory of the population dynamics of infectious diseases, here there's a very simple formula coming from Anderson and May, where the reproductive rate of the spread of a pathogen or of is the product of the probability of transmission, which in the case of Ebola is low. I mean, except if you have really close contact to bodily fluids. But anybody else, if I have Ebola here, that's no problem for you here sitting. If I would have measles or TB and so on, that would be another story. That multiplied by the number of contacts, very limited because one, you die after a week or two. Two, it's only people who have, you know, close contact. And D, the duration of infectiousness is very limited in Ebola because we are an accidental host and the virus kills us in a week or two. So in theory, this should not have given rise to an epidemic. And yet, the rest is history. We know that in December 2013, now nearly 2 years ago, in a place called Kekegu in Guinea, in the bordering area with Sierra Leone and Liberia, this epidemic started and spread like wildfire across 3 countries, also affecting capitals and killing over 11,000 people, which is about 9 times more, 8 times more than cumulatively all people who were killed by Ebola as far as we know, which was about 1,500 in close to 40 years, because next year is 40 years since we know about Ebola. So what happened? The first, and the dynamics were very different from country to country. Liberia, where the epidemic now also has been declared over for several months. Sierra Leone is now in its 5th week without any case. And in Guinea last week, there were another 3 cases. First hypothesis, is this a different virus? The virus is not identical, but it's basically, it's also the Zaire strain. So the Zaire isolate that, that we isolated in '76. However, it is, there is a growing diversity and diversification genetically, which is also need for epidemiological tracing, so we can find out who belongs to which infection transmission chain. What actually has changed is the environment, and what it was a real fertile ground is from an editorial in Science of last year, I call it a perfect storm. A combination of three countries that came out of decades of civil war, corrupt dictatorship, professionals left the country, health systems collapse, high mobility, good roads, which you don't have in Central Africa in many cases, and particularly the lack of action by the by the governments. All that made a very lethal cocktail, and it illustrates that something that usually is a local affair can become a major issue, not only on the regional level, but in this case, because for the first time there were cases exported to other countries, a global problem. Now, we've learned a few other things that we didn't know. One is that here you see in the epidemiological curve for Liberia, and after several, it was ending in like May, there were the last cases in Liberia, but then after about 2 months without any case, suddenly cases appeared again. And this was due, we know today, there were 2 papers in the New England Journal of Medicine last week, showing clearly that this was due to sexual transmission. Already in 1976, we had isolated Ebola virus from the seminal fluid of one laboratory technician in Porton Down in England who had become accidentally infected, but there was no documentation in the field of this. Now, there are about 7,000 men who survived from Ebola in West Africa. We have no clue what percentage are excreting Ebola virus, for how long, etc. So this is, okay, I've been working on sexually transmitted infections my whole life, and now the circle is round. Even Ebola can be sexually transmitted. So that is something that we need to bear in mind. Secondly, we also have learned that the virus can not only cause acute infection and very lethal in many cases. The case fatality rate here was 70%. The first outbreak, 90%. In some cases, depending, can be as low as 30%. It also depends on the kind of supportive care that is being given. Now, here we also see that not only can Ebola survive for a long time in testicles, but also in the vitreous fluid, in the eye. These are the eyes of Dr. Ian Crozier, who survived Ebola, and a very severe infection. On this left eye is this normal blue eye, and on the right side you see this eye turned green because of inflammation. But also in the UK we had a nurse who was cured from Ebola, we thought about over 6 months ago now, and who was then readmitted with very severe meningoencephalitis. We know that the virus is the same, it's not a reinfection or so, it's really a virus was there all the time. Now, did the measures that we all did and the international community contributed together with the locals, did they make any difference? This is from a paper that came out last week also in PNAS from our school, and estimating that the additional beds that were organized in the Ebola treatment unit saved about 56,000 lives. But if we would have had these beds 1 month earlier, an additional 15,000 people would have been saved. So it is really a matter of acting promptly, both from an organizational perspective and epidemiologically. Now, the good news is that in contrast to HIV infection, it seems that we have a vaccine against Ebola that can work, and probably more than one vaccine. And I must say I should pay tribute to Canadian science. This is a vaccine you know, a VSV, recombinant VSV vector vaccine that was developed in Winnipeg at the Public Health Agency High Security P4 laboratories. And it was shown in a study in Guinea. Our school was involved in that, and that it could contain an epidemic, an outbreak, through a technique called ring vaccination. And some other vaccines are now being tested based on adenovirus constructs and a prime boost vaccine. So that for the first time during these acute outbreaks, major outbreaks, research was done. It was very difficult. It came perhaps a bit too late, but it was done. And it was from this kind of you know, vaccine research, but also social sciences and more fundamental type of pathogenesis, because we still don't know exactly how Ebola, what the pathogenesis is. And it also is reminding us that our usual classic R&D architecture and incentives don't work when there's market failure. These vaccines were developed. The two constructs coming from the US were funded by the Department of Defense. And the one also here in Canada was not developed because of public health concerns, but because of bioterrorism concerns. I say that's good that it happened, but we need better than that and a better incentive. And so there was a call by Stanley Plotkin, Adel Mahmoud, and Jeremy Farrar, Wellcome Trust, to establish a global vaccine development fund for where there is market failure. And it's something that I would say is mindful also of like what has been done in HIV infection, although there is clearly a big market. Finally, some lessons that, and we can go on forever in terms of lessons, but first of all, we should never forget that emerging infections will continue to rise from animals. So far for no future in infectious diseases. They will continue. Even if on a global scale, in global health, infectious diseases and maternal mortality and so on, child mortality and undernutrition are you know, diminishing in terms of burden of disease. It's now chronic diseases that are coming up, you know. So they will continue. Secondly, I think particularly in AIDS, we were able to very rapidly translate science and what came out of new knowledge into action, be it new treatments, but also from behavior science, from all kinds of trials. So that was really important to stick to that. But it was also driven by human rights considerations, because that was driving and accelerating the access to, for example, treatment. That was not a scientific démarche. Thirdly, people affected, particularly people living with HIV, were a driving force, and I think that's something that we see more and more in health. Fourth, there are good politics and bad politics. We need the politics, because otherwise the science is not going to have any impact, and there won't be money, and so on. We had the worst and the best that came out in people, also in politics, from discrimination, a president of South Africa saying that HIV didn't exist, and so on. But good politics is where there's leadership. And the most difficult issue here of all was not sex is sometimes difficult in some societies, but had to do with drug use and injecting drug use. We still have an epidemic that's getting really out of control in the former Soviet republics. And we know there's very strong evidence that providing clean needles and syringes, substitution therapy, that saves lives. And yet it's against the law there. It's the biggest failure that I personally feel. I was never able to convince the authorities there to even allow it. China has gone the way and just embraced it after quite some hesitation, but not these countries. And as a result, people die. Fifth is that we've had very specific mechanisms for control, for financing, and for R&D, and I think that's also a lesson for others. Sixth is that, okay, if you don't have systems for delivery, it's very difficult to deliver the science or to know early enough that there's an epidemic, and above all, act promptly. So if you want to know more of the petite histoire, as they say in French, You can read that in these two books, in the two national languages of the country. Thank you very much.